Thank you, Mr. Chairman. Good day to you all. In this panel, I will be talking about description and neurobiology of treatment resistance in schizophrenia. Chlorpromazine was found in 1950. Since then, schizophrenia became a treatable disease. Until that day, it was thought that schizophrenia was a disorder with no ailments. However, 30 to 50% of the patients are resistant to pharmacological treatment. Antipsychotic drugs and poor response to antipsychotic drugs can be seen in the first years of the disease, or it can be seen, observed in the later years of the disorder. Early unresponsiveness have its relationship with neurodevelopmental and pathological factors and treatment-free period, and delayed resistance is said to be related to pathological mechanisms. Treatment unresponsiveness can be related to severity of the disorder. Those who are resistant to treatment can be suffering from a more severe disease, or it can also be completely independent of the severity of the disease. Sometimes a very severe patient can be seen to benefit from drug treatment completely. Substance abuse, concomitant disorders, lack of family support, lack of adequate dose, inadequate patient-doctor relationship could also be observed as resistance to treatment. Treatment to resistance to treatment was first defined as a chronic disease or a disease requiring frequent hospitalizations. Today, it is seen that frequent hospitalizations are markers of treatment resistance. Lack of psychosocial programs, lack of compliance on behalf of the patient, or violent behavior could also cause long hospitalizations. Therefore, long hospitalizations might not be a good measure of treatment resistance. 90 to 80% of the patients can have occupational and communal disability. Most of the patients only respond partially to the drugs. Therefore, complete response or response as present or not present is not really adequate for definition. Partial responses and full responses are not really qualitatively discriminated as such. Meltzer's definition is not being able to go back to the functionality level prior to the start of the disease. This is also a beneficial definition. Not being able to go back to functionality prior to disease actually describes 90 to 80% of the patients. Therefore, this definition might not really be beneficial. Professor Meltzer told us about clozapine and the story of clozapine. In 1988, in the US, in order to stop the clozapine study, FDA wanted drug resistance definition in order to go through with the clozapine studies. They did not think that tardive dyskinesia was enough. Therefore, Therefore, in order to convince FDA to go further with the clozapine studies, they had to have a strong definition for treatment resistance. Treatment resistance and its definition was produced based on this need. BPRS above 45 and CGI above 4 points means medium severity for BPRS. I am mentioning this for those of you who are not familiar with BPRS. Or CGI equal to or above 4 points. All of these point to medium severity of disease. Lack of wellness in the past 5 years. Unresponsiveness to drugs. 1,000 milligram chlorpromazine equivalent dose with at least 2 typical antipsychotics from 2 different chemical groups in the past 5 years, and lack of response with 6 weeks of treatment for at least 3 periods of treatment schemes. Professor Meltzer and I discussed about the haloperidol dose. 20%, less than 20% of improvement in BPRS or lack of tolerance to drug. To summarize, at least 3 unsuccessful treatment failures, at least 3 treatment failures for 6 weeks, and haloperidol not being successful with haloperidol with 6 weeks of prospective treatment are required for drug resistance. Kâzım and colleagues showed that only 3% of the patients benefited from haloperidol and 4% showed improvement with chlorpromazine, according to the study by Kâzım and his colleagues. Another study by Kinan and friends, 2 drug trials, one towards the future, one towards the past. If there are 2 failures, the third to be a failure, the possibility of the third being a failure is 7%, according to this other study. Kâzım and Marder reported that 4 to 6 weeks of treatment is adequate. If the patient does not respond by the 4th week, you do not need to wait any further because the patient is not likely to respond, was the report of the authors. An author from Karolinska showed by PET that 400 milligrams per day of chlorpromazine blocks 80% of the dopamine receptors in the basal ganglia. Therefore, higher than 400 milligram per day doses of typical antipsychotics might not be able to give any extra benefit. At least 2 drug failures of 4 to 6 weeks of treatment duration with doses equivalent to 400 to 600 milligrams per day of chlorpromazine. Occupational and social poor functionality in the 5 years with no periods of wellness, and BPRS score above 45 points are the requirements of treatment resistance. Now I want to talk about neurobiology of treatment resistance. What can be causing the treatment resistance? Gene polymorphism. It was discussed very thoroughly in the morning. Gene polymorphism might change the metabolism of the drugs, targets of the drugs, or the transporters of the drugs, and cause unresponsiveness to drugs. Disease-related mechanisms are as follows: progression of disease in spite of treatment, structural brain changes, changes in neural networks, and changes in drug targets or changes in uptake of the drug into the brain. Thirdly, drug-related mechanisms. These are as follows. Decrease in the effect of treatment, functional tolerance, or stimulation of enzymes metabolizing the drug. I want to go through the pharmacogenetics primarily. Genetic changes cause changes in the affinity of the neurotransmitter receptors or functionality of the receptors, causing pharmacokinetic changes. DRD2 and CYP2D6 gene polymorphisms cause no relationship between treatment resistance and these polymorphisms. It has been proven in Brazil with a large patient group that D2 receptors and cytochrome P450 2D6 polymorphisms had no relationship with treatment resistance. There are 12 polymorphisms which have been related to treatment resistance. In a study from US by Huang and colleagues, in Caucasian patients, nothing was detected, but with Afro-Americans, TAC1A, TAC1B, and RS112539 polymorphisms were seen to foresee clozapine response. Umit Yashar talked about CYP2D6 gene and CYP2D6 gene mutations and increases in gene numbers. Mutation or complete deletion, we know that are related with high plasma levels. High metabolizers might have 2 to 13 copies of these genes, but we know that this is only responsible of a part of the story. Schizophrenia patients who are not resistant to treatment, the patients who are resistant to treatment, only a minority are not benefiting from the treatment due to these gene polymorphisms. Again, there are various literatures stating relationships between polymorphisms and schizophrenia and treatment resistance. I want to talk about RGS4. This is regulator of G protein signaling for polymorphism. This is a very well-known gene which is known to be related with schizophrenia risk. However, polymorphisms with this gene plus treatment response, there is no relationship have been shown between these two. This is a Wheeler-related gene, Wheeling gene. During neurodevelopment, and we know that this protein is related. This protein has a role in neurodevelopment, and we know that this protein is related with schizophrenia. I want to talk about one polymorphism. It has been shown that one polymorphism of this gene is related to treatment resistance. What about drug transporters? Transporters carry the drugs through the blood-brain barrier. We have no time to talk about in detail about the blood-brain barrier, but there are certain multi-drug transporters that are located at the capillary brain endothelium, and they push the drugs back towards the lumen of the vessel. The most well-known protein is PGP. PGP has been shown to play a role in resistance in cancer. PGP knockout mice have been shown to have more antidepressants in their brains. However, clozapine is not carried through PGP. Therefore, we do not have a model for treatment-resistant schizophrenia. We cannot say anything further on that. I have 1 minute left, therefore I am skipping through my slides. I'm having a difficulty in adapting to these changes in our timing. Between 1980 and 1989, 33 CT studies were put through a meta-analysis, and it was shown that large ventricles had no relationship between treatment unresponsiveness. The meta-analysis has disproved our prior belief that large ventricles were related with treatment unresponsiveness. Some patients have shown a decrease in frontal and temporal gray matter volume, which was related with treatment response. Lieberman and friends in an 18-month monitoring study have shown similar results. Patients with large ventricles at the end of 18 months have responded to treatment by 60% and 40% unresponsiveness. We see that those patients with small ventricles go into remission in a larger percentage. Those patients who have small ventricles in the beginning but have large ventricles later on, when they are compared to the patients who have small ventricles in the beginning, have similar responses, similar results. This is a prospective study. Neuropathology. This is gray matter. 39th area, inferior parietal lobule. In white matter, you see scarce neurons. We know that there are scarce neurons. The number of these neurons are larger in schizophrenia patients. This is a classical information. Kirkpatrick and friends have shown that this cell condensation was much larger in comparison to the controls. If this is a migration anomaly, that is, the cells around the ventricle not reaching the cortex, being stuck within the white matter, if that is the problem, deficit patients, that is, unresistant patients to treatment, have larger numbers. My last slide, if you allow me. Physiopathology of treatment resistance. Lieberman suggests a model. It's an old model, 10-year-old model, but I believe that it has a very powerful explanation potential. First stage, cortical neuropathology caused by genetic and epigenetic factors, could be caused by birth trauma could be caused by early disease. This is the first stage. There is a deficit in the monitoring of the cortex over subcortical structures. The second stage is the stage where the patients go through during their adolescence. During adolescence, the dying off of the neurons during the development, the weeding out of the neurons during the developmental phase is problematic in the second stage, and the third stage is caused by neurotoxicity and structural changes. Behavioral sensitization can be thought of as a reverse tolerance. Same amount of cause less response, and the third stage is the neurotoxicity and structural changes. According to this model, in the period of adolescence, uncontrollable dopamine, ventral tegmental limbic striatal pathway dopaminergic activity causes behavioral sensitivity like neurochemical sensitization, and thus resulting in treatment resistance. When the structural changes are observed, then the disorder advances into a more severe stage. Recurrent psychotic episodes, and it explains the difficulty of these patients with recurrent episodes.